Hello, my name is David Sallman from Moffitt Cancer Center in Tampa, Florida. I'm an associate member in the myeloid section head in the malignant hematology department. It's really an honor and pleasure to be here and look forward to all of our discussions. My focus topic will be on future directions in the management of higher risk MDS, and we'll really highlight several novel therapies, as well as think about options that we may have after, standard of care frontline therapy. And again, look forward to these discussions. So starting out with a case, we have a 67-year-old male who presents with severe pancytopenia, 12% myeloblast, trilineage dysplasia, and really part of the standard of care workup would be next-gen sequencing profile. And notably, it only showed one mutation, but showed a P53 mutation with a very high variant allele frequency of 55%, as well as an associated complex karyotype by cytogenetics. This patient is really otherwise fit, minimal comorbidities, still actually walking a mile per day at the time of presentation. And really based on the poor standard of care in this patient population, we discussed clinical trial options, and the patient was ultimately enrolled on a trial of azacitidine with magrolimab. The patient did have a 2-gram drop in the hemoglobin, actually about 4 or 5 hours after the first infusion, and had some notable increased, symptomatic anemia. This was transfused and actually subsequently really had no issues and no infusion-related reactions. This patient achieved a marrow response or blast clearance with hematologic improvement, and actually subsequently achieved a true complete remission by IWG criteria, and ultimately bridged to allogeneic stem cell transplant. And again, I think this case both highlights an exciting new therapy, as well as a number of very important considerations to think about both on and off study, and what are our goals of therapy in a patient such as this.
Before you continue, and I know you're going to get into this, but just a couple things in that write-up I wanted to ask you about. One, you referred to other magrolimab-related adverse events. Like the only thing I've really heard about has been the anemia. What else do you see?
So you can see infusion-related reactions predominantly in the first cycle, kind of like any monoclonal antibody. So that would be the most common other adverse event. But notably, we've not really seen immune-related adverse events. There's been a couple rare reported cases of pneumonitis, although these were also during the COVID-19 pandemic and may really not have been related.
And the other thing is, and again, you may get into it as we move along here, but the diagnosis of MDS with 12% blasts,
Mm-hmm.
and the issue of what is MDS and what is AML. Any thoughts about that?
Yeah, I think so. I definitely will get into this in part of my talk, and Garcia Monero may get into it a little bit. I think obviously this overlap of MDS AML has created a lot of discussion, and I think the good part is thinking about some of these diseases together will hopefully open up more options. I actually think this case in P53 in particular is the one that is most important for us to unify now. I think in some of the other molecular subsets, I still think we have a lot to learn on outcomes to therapy and best options. Some may be better directed for AML therapies versus MDS therapies. But for P53, we really want to think about this group as a homogeneous entity so we can really finally improve the standard of care for this patient group. So I intentionally had this sort of 12% blast for this exact patient to speak to the point that you just brought up.
Yeah, it's a great case. I guess just that again, I know you're going to get into it, but I'm just my curiosity is getting ahead of me, I guess. But just out of curiosity, what would you have done? What would you typically do with a P53 positive AML in the same situation?
Yeah, so I think actually, yeah, for trial, to be the leading trial right now in the world for this group is the phase 3 Enhanced 2 trial. So this is magrolimab versus azacitidine venetoclax. I think that, and this is independent of age. So it's patients 18 or older. It's not old versus young, fit versus not fit. This is saying our standard of care is bad. Azacitidine venetoclax is probably as good as we have as our current standard of care, but median survival is still 6 months. And so the FDA has recognized that. And so we're looking at doublet versus doublet, because I think we have to really establish what is our best backbone before we maybe think about triplet and other combinations in this patient group.
Just out of curiosity, through indirect comparison and your clinical experience, what do you think is more effective in P53 positive AML? Do you think magrolimab actually, right now, we know enough to say that it's better than magrolimab AZA?
Yeah, I mean, so everything is, single arm trial, which has its own caveats. But if we take a look at really across three different studies, including an IIT by Naval Daver at MD Anderson Group, we have median survivals in sort of the 10 to 17-month range, which at least in large single arm studies has been as good as we have seen. So I'm very excited, especially for Enhance 2 in the P53 subset, that hopefully we will have a new standard of care. But we still have a ways to go. We're not curing a majority of these patients. We are improving survival, improving chances of getting response, hopefully getting more people to transplant. But I'm hoping we'll establish a new backbone to which to build upon, and also to recognize that we need to think of this group completely by itself and stop putting them in sort of all-comer MDS and AML clinical trials.
Again, just out of curiosity, and I know you're going to get into this, but I'm just curious, when is it projected that we're going to see data from those two phase 3 trials, the one with MDS and the other AML?
Yeah, for the MDS study, I mean that trial has completed accrual, and it is a survival endpoint trial, so obviously have to wait for events. But I'm hoping that maybe we'll have results even in this year. I think Enhance 2 and then subsequently Enhance 3, which will have a subset of P53 patients, probably looking at least in a 2024, 2025 periods, kind of based on when these trials read out. But for P53, because the survival is so short, we could actually potentially expect readouts even in the 2024 time period.
That's really fascinating and exciting. Okay, sorry, but it's just such a great case. I had to
Yeah,
ask you about it.
yeah, no problem. So I think as we're going to get into a lot of data on outcomes to different novel clinical trials, I think it's important to think about what is a response in MDS. And so this is just a figure that we made just to kind of highlight some differences between our older 2006 IWG criteria and the updated 2023 criteria that were published in Blood by Zidane and colleagues. And I think what's important is now that the ability to get to sort of a CR or CR equivalent is much more reasonable. Actually, there's data, for example, we ran a CPX 351 trial in MDS, and if we use MDS criteria, our CR rate was around 20%. If we use AML criteria or ELN, it was 50%. And so again, what we've now done with the updated system is now the hemoglobin for true CR has been lowered to 10. That's maybe a minor change, but we now have either a true CRH equivalent identical to what it is with ELN. We actually validated this in a nice study with Andy Bruner at Mass General. Or there's this CRL, which again basically has one peripheral blood count that has improved at least with the blast clearance. I think the bottom line is blast clearance plus hematologic improvement is extremely meaningful in these patient populations and really is our composite good response. At the same time, if you only clear blast with no hematologic improvement, there's really no benefit. And marrow CR, for the most part, has been removed from the updated IWG criteria, maybe with an exception of patients that are getting bridge to transplant where that may still be meaningful. So again, thinking about MDS and AML, and I think if you're going to talk about P53 at all, and obviously our cases there, we need to think about this group in its entirety. So I think everybody is, or maybe people are not aware, but there's been two seminal publications, the updated WHO, as well as this new classification called ICC, or the International Consensus Classification. And for the most part, these two systems align quite significantly. The one big, I would say, kind of controversy or discussion is around this MDS/AML category by ICC. So if you have 10 to 19% bone marrow myeloblast, again, it's recognizing that there's a high degree of overlap amongst these patients, and we should really be thinking about these groups together, both thinking about MDS or AML options. Now, I still think there's a lot of work for this to be done, and I don't think it's created equal for all mutations, but I want to highlight that for P53, this is maybe the most important group to think about P53, especially the multi-hit high VAF complex karyotype, as a singular disease and not get bogged down by an arbitrary blast cutoff. So how can I support these data? So this is really, to me, the seminal publication. This is by the Hovan group. It's really the largest to date that has looked at this. And so this is looking at AML patients that are in red, or MDS excess blast patients that are in orange. And you can see in curve B that these survival is completely superimposable. What's really interesting in this study is actually the blast cutoff was 5%. So it's actually a little bit different than the 10% cutoff I showed you in the past slide. And I actually would argue for P53 mutant disease that we should really maybe even think about 5% blast or greater as sort of a homogeneous entity. Again, if it's in the setting of high VAF, complex karyotype, or a biallelic hip mutation. But again, we need to be thinking about this disease as a singular entity. I think before we start getting into data, I think the last thing is of course, most people and most centers are checking next-gen sequencing panels. P53 is a gene that is included in all of them, but one challenge can be, can I wait? And, some panels at local centers can take a month to turn around. I think it's starting to get quicker and quicker, but people are worried, do I have to urgently treat these patients? I would actually argue, even despite this, is that for P53, most are pancytopenic and we have time to wait. But I think, can you have a clue? Can you have data that may suggest, hey, this may be P53? The NGS is really critical because the outcomes in this group with standard of care options are so poor. And the answer is yes. So one is you could do an MDS FISH panel. This includes chromosomes 5, 7, 17. And this could typically turn around within 24 hours at many places. And again, if you have an aberration of 5 with 7 or 5 with 7 and 17, over 70% and up to 100% of these patients can have P53 mutation. Another way is just to do a standard P53 immunohistochemistry. This is not checking for actual mutation, but what it's showing, and this is the brown stain on the top panels, is an accumulation of misfolded protein. And this really only occurs in the presence of P53 mutation. It's actually something you can serially track. This is actually a representative case in our JCO publication with eprinetapop. But again, when you achieve true complete remission, you can see again clearance of this protein. And what's important, again, speaking to this overlap of MDS and AML, is the MD Anderson group in this publication recently in Blood basically showed identical data to what the UK group and our center did earlier in MDS. So these three findings, as well as a history of therapy related, can be quite useful. And lastly, obviously ring sideroblast is a good subtype of low-risk MDS patients that has SF3B1 mutation. But we had, noted in excess blast patients kind of this concordance with P53. And so we looked at this both in our cohort as well as a very large validation combined cohort. And what you could see is if you have more than 5% blasts with more than 5% ring sideroblast with the presence of at least 5% blast or greater, over 70% of these patients are P53. And if you then add that with the MDS FISH panel, having aberrations of chromosome 5, you then have over 90%. So again, ring sideroblast turns around a day, MDS FISH panel turns around a day, P53 immunohistochemistry can turn around a day. Putting these things together, you can actually predict most patients, even before the NGS results get back, whether or not there is a P53 mutation. Again, I still think it's important to wait in all cases, but this can maybe help give some certainty in that setting. So now thinking about novel therapy and really tasked to focus on anti-CD47 therapy and really magrolimab being the leading agent. But this is really the preclinical rationale in the MDS patient population. This was really has been led by Ravi Majeti, Mark Chow, and others at the Stanford group. And what this showed was if you look at patients that have excess blasts, that if you look at their CD34 populations, CD47 is significantly overexpressed, both versus normal stem cells as well as patients with lower risk histologies. This has been showed in several follow-up publications with clinical risk, again, correlating with increased CD47 expression. And similarly, the pro-eat me signal, so the pro-eat me, again, calreticulin being the main one, is also increased. So you have more of the increased eat me signal, more of the increased don't eat me signal, really providing rationale to target this to identify, get significant activity. And then a lot of the animal models, just because animal modeling in MDS is very challenging. This is AML with histographs on the bottom right, but really you get this complete wipeout of leukemic blast. And what is shown by these black arrows, which is pretty interesting, is actually macrophages engulfing a bunch of blasts, really speaking to the activation of phagocytosis. There is also some data that shows that azacitidine can actually upregulate the pro-eat me signal, as well as in xenograft models really had profound synergy. And so that was the rationale for the combination. But again, magrolimab is a first-in-class macrophage immune checkpoint that targets this axis. I always like to show these videos, and we'll see in the presentation. Again, these cancer cells are in green, the macrophages are in orange. In the absence of antibody, you get no phagocytosis, whereas in the presence of magrolimab, you get this rapid induction. What's important is that if you do not have a pro-eat me signal, you do not really have any activity. And so this is how we're able to spare normal cells, which largely lack pro-eat me signals. There is one notable exception of old red blood cells, and I'll comment on, again, this sort of on-target toxicity that we can see. Again, just speaking a little bit to the antibody structure for magrolimab, it is an IgG4 monoclonal antibody, and that may really be the best optimization to both not have too little and not have too much activity. Again, IgG4 antibodies have had the most activity to date in the sort of anti-CD47 class. Again, these are just the videos here, just real quickly, again, showing the cancer cells in green, the macrophages in orange, and again, you can see this nice rapid induction. So this led to a very large phase 1 clinical trial that included both higher risk MDS patients that were intermediate to very high by IPSSR, as well as acute myeloid leukemia patients largely restricted to P53 mutation. For today's talk, we'll focus a little bit more on the P53 cohort, although I'll show both subsets. The azacitidine is really a standard 7-day schedule, and the magrolimab is given with this priming dose at 1 milligram per kilo. This is to mitigate this on-target anemia. It's then ramped up over the course of this first cycle, and again, ultimately given weekly, and then starting with cycle 3 and beyond is given every other week. What may matter a lot for synergy with anti-CD47 therapies is getting full saturation of the receptor. So CD47 is widely expressed on all cells in our body. Again, the reason why we don't have toxicity against normal cells is a lack of pro-eat me signals. So there have been some earlier anti-CD47 therapies that have really failed or showed relatively limited activity. And if you look at their PK or CD47 receptor occupancy, it was not fully saturated. What was important here is when we switched from 1 week to 2 week, you could see that we still had 100% saturation. But what's important, if you space out further, you may start to lose this and actually efficacy may drop. And so what's important, both sort of in really all of the phase 3 studies, is we have decoupled the magrolimab from the azacitidine or azacitidine venetoclax combination. So let's say you need to hold for cytopenia toxicity, the magrolimab can continue, and part of this is to really keep this saturation. We have a little bit of data that this may correlate to overall better response rates. From a side effect profile, again, the side effect profile has been pretty predictable. We do see this on target anemia, and I'll have a slide in a moment to focus on that, but we really do not see exacerbations of neutropenia, thrombocytopenia. These are very critical when you think about combinations in elderly patients, both with azacitidine or azacitidine venetoclax. We see some of the GI toxicity commonly associated with azacitidine. Infusion-related reactions, you can see that it can occur in up to 30% of patients, but most of these are grade 1, really grade 2 or 3 are quite rare. And most patients are able to stay on drug with a very low 30, 60-day mortality. Again, so what about this anemia? Again, old red blood cells, a normal body, one of our body's mechanisms for clearing these is through this access, and thus you can get this large drop. And although the average drop can be between 0.7, 1 gram per deciliter, we have had patients drop 3 or 4 grams per deciliter, and thus we had to mitigate several safety strategies. So one is to keep the hemoglobin above 9 grams per deciliter on the first, both the day 1 and the day 4, so the first 2 infusions. And then the most important part is actually to recheck a blood count 3 to 6 hours afterwards. This is to catch that large drop, not to send a 75-year-old patient home that may now have a hemoglobin of 5. But the important part is after this first week, it is really not an issue. And you can see over the course of time, hemoglobin's going up. Of course, this is correlating with response. And what has been found, and this was been shown in a follow-up abstract at ASCO a year ago, is that red blood cells that are chronically exposed to magrolimab actually lose CD47 on their cell surface. And this is known as RBC pruning. So this is really a first week issue, slightly a first cycle issue, and then over time, really not. But it would, again, assuming that this combination gets approved as a new standard of care regimen, I do think we'll have to work with blood banks. It can interact similarly to daratumumab. And I think it just creates some logistical challenges that we'll have to work through together for the first week. But after that, it's actually relatively straightforward. So what about the activity? So this is a really large phase 1 trial. Again, these data have been recently published in JCO. This is the MDS cohort, 95 patients. You can see that over about three quarters of patients responded. Most of these responses were either true complete remissions or marrow CRs with hematologic improvement. Again, remember from sort of the earlier slides, that is really the response that we're going for. We only had about 10 to 15% that were marrow CRs alone, again, most associated with hematologic improvement. If you look at the waterfall plots on the right, most patients having blast clearance, actually some of the patients without a change were patients that did not have an increase at baseline. And again, the time to remission was really at the first evaluation. Time to true complete remission, though, can deepen over time. And I'll show some data on that in a moment, with about a third of group becoming transfusion independent. So this is what I was alluding to a moment ago. And so this is a novel immune therapy. And I think we all know this in solid tumors, that it can take some time to get sort of best response. And although we do see rapid responses, particularly hematologic responses in the first 2 cycles of therapy, you can see many of the patients don't change to the true CR or this orange magenta, color until cycle 4 of therapy. And actually about 20% of patients could even take longer, up to 6 cycles or longer. So I think the important part is we're not seeing rapid progressions. You could see there was only one progression even early, like out past that 6-month cycle. And so you have time to achieve best response. And I think why this is meaningful is we're really thinking about this total therapy concept, getting the best depth of remission in order to ultimately get our best outcomes to transplant. So this is a little different than venetoclax, where maybe you get these very rapid responses, whereas it'd be important to take time, push through 4 cycles, maybe 6 cycles of therapy, even in your transplant eligible patient population. So what are our survival data? Of course, this is what we're really trying to improve. And so a relatively mature follow-up at 17 months. We had a median overall survival that was not reached, although you can see that the curve is approaching 50%. But I think it's important, and I'll show the P53 data in a moment, is parse this by P53 mutation status, which is really what we're doing when we think about this patient group. So now over 60% of patients were alive at data cutoff. Again, these data do look quite favorable versus a historical reference where the median OS, at least with real world data, is about 17 to 19 months with standard of care azacitidine. Well, what about transplant? So transplant, again, we're now doing regularly up to the age of 75. I actually have an 80-year-old that is potentially going to go forward with transplant really as we speak. So we're pushing these age boundaries. Long-term survival, if you look at, large transplant cohorts, has typically been around 40, 45%. And so I think looking at these data, now again, smaller subsets, but we took almost 40% of these patients to transplant. And again, survival at 2 years is approaching 80%. These are double from what we would historically expect. Again, these are trial patients, single arm studies, but I think this is a really key secondary endpoint in the phase 3 ongoing study, is how are our transplanted patients doing? Is this because they're getting a better response, functional status improvement? I'll speak to that as well in a moment. Now, again, looking at that P53 group, we have a median survival of 16 months. And at least in prospective MDS cohorts, the survival has typically been 7 to 9 months, really in all trials, except for one. And I'll comment on the phase 2 sabatolimab trial a little bit later in the talk. But very impressive data, but we still have a ways to go. These patients are not being cured outside of going forward with transplant. And so my hope is this establishes a new standard care backbone therapy that we can thus improve upon. Again, only 4 patients were transplanted. So this survival here that we see here is not biased by transplant. Again, you can see, again, several long-term survivors in that transplanted group. Well, what about MRD? I mean, this is like a huge hot topic in AML. Every lecture has MRD throughout it. We don't have that in our MDS talks. And I think part of that is because we've had lack of therapies that can achieve MRD negativity. But now, as we have multiple novel combinations moving forward, I think this is going to be really, really important. So this was using multi-parameter flow cytometry, same type of panel that we would use in an AML trial, has a cutoff of 0.02%, so quite sensitive. And I'll get not huge numbers of patients, but very clearly, if you achieved MRD negativity with the blue curve, the survival was better. And this actually was highly relevant in the non-transplanted group. And this may make sense. I think if you can get patients to transplant, obviously there's a GVL effect independent of MRD, and maybe that's why we don't see as much separation in the transplanted cohort. But in the non-transplanted patients, again, achieving a better depth of response predicted overall a longer overall survival. And again, achieving MRD is really a new goal in MDS. I think adding this with deep sequencing is really the way of the future. But again, this is actually, I think, the first prospective MDS trial that has looked at the role of MRD. And again, it similarly shows data like we would expect in AML patient populations. Well, what about P53? Of course, our case in the beginning was a 12% blast. And so a high degree of overlap between MDS and AML. So this is the same trial, but the AML cohort of patients, which we amended to essentially enroll only P53 patients after early on. So we have 72 P53 AML patients. This is actually the largest prospective P53 specific cohort put together. You could see a 50% overall response rate with a true CR rate of around 33%. And again, half of those CRs achieving MRD negativity by that same high sensitivity flow, and a subset of patients achieving complete cytogenetic response. Well, what about the survival? So the survival, does appear to be a little bit less. And although there is clearly a high degree of overlap between MDS and AML, I do think the severity of cytopenias can sometimes be worse in AML patient populations, maybe a little bit more enrichment with multi-hit complex karyotype disease. So the survival here is 11 months. Again, this is still almost double from what we expect with HMA venetoclax, which is our current standard of care in this patient population. But particularly, again, transplanted group, which some people are concerned, should anybody with P53 go to transplant? I think there is enough data that show maybe a 20% long-term survival. Again, small numbers of patients, but clearly looks favorable. Over half of the patients alive, at least at the data follow-up. But again, is this speaking to the quality of the response prior to getting that patient to transplant? Lastly is looking at a triplet, and this is a really nice IIT, at my colleague's center, MD Anderson. This has been led by Naval Daver, which is HMA, venetoclax, magrolimab. These data were last updated at ASH of 2022, and again was predominantly a P53 cohort. You could see again response rates maybe even a little bit higher, although this is AML versus MDS responses, 72% composite response rate. But again, I think what matters most is thinking about the survival in this patient group. So, what they did was like a analysis looking at historical HMA venetoclax. And again, we have this 6 months come up again versus 10.4 months here. So clearly a doubling of survival. I'm very hopeful that this will support a new standard of care in P53 AML. But again, we have a ways to go. And my big question from this is the doublet aza magrolimab or the triplet aza venetoclax magrolimab better? To me, the survival was the same as our doublet. And I'm actually most interested in the doublet moving forward in this patient population, but we'll ultimately see as several of these studies read out. So what will lead to the sort of the standard of care change? So this is the first trial that we're eagerly awaiting for. This is the phase 3 enhanced MDS trial. So again, this is up to a 20% blast cutoff, disease of intermediate to very high. It's a double-blind placebo-controlled trial with co-primary endpoints of CR and OS. And we're eagerly awaiting these data, which again would change the standard of care for high-risk MDS. But what about in AML? Again, specifically for P53, I think we at least have to comment. There are 2 ongoing phase 3 trials. The enhanced 2 is, again, one I'm most excited about, which is for all-comer, 18 or older, independent of age, fitness, looking at aza venetoclax or aza magrolimab or aza magrolimab versus induction chemotherapy. This is to establish a new standard of care for all-comer P53 AML. This has a sole primary endpoint of overall survival. And then based on novel, work, there is a triplet versus doublet trial for elderly AML. Again, probably around a quarter of this cohort will be P53, so there will be some cross-trial comparisons. And then lastly, and this is a concept I'm helped leading with Rory Shalis, Amir Zidane within MyeloMatch, which is this elderly basket for patients over the age of 60, is looking with the oral decitabine agent that we've heard some from Dr. Garcia Minero. Again, this is looking with that, again, at triplet versus doublet. And again, this is only for P53 AML. So then we can really say, hey, is the triplet or the doublet looking better? Again, there's a little bit of apples to oranges comparison, but I think from all of these studies, we can really establish what is best for this patient population.
So before you go on, just one thing you had mentioned earlier that maybe you could elaborate on a little bit in terms of the biology of P53. So I thought that slide you showed with the IHC was very interesting with the unfolded protein.
Yeah.
Can you explain a little bit about your vision for like what you see in P53 patients? And is that similar, I know, to what you see with P53 in like solid tumors?
Yeah, so maybe to answer the second question first, I think that the difference in solid tumors is, P53 mutation is the most common mutation, like 50% of all solid tumors, but it's really in the setting of having hundreds and hundreds of other mutations, really high mutational burden. And I think that complexity speaks to some of this difference. It may also speak to some of the sensitivity to IO therapy, which of course has been paradigm shifting. In myeloid malignancies, we have rare other mutations. Actually, when we run large panels, P53 is the only one in about 2/3 of patients. So I think there is some unique differences. I think to the pathobiology, actually, a really seminal publication by Ben Ebert at Dana-Farber showed with the most common hotspot mutations, so couldn't do all mutations, but 6 of the most common hotspots, that it leads to this dominant negative effect, this loss of function, this P53 protein that really can't do it. So I think we know that ultimately we're losing P53 function is really the predominant loss that we have. I think how we combat that, I think we need to have as many novel, innovative techniques to try to do that. One, of course, is this of novel IO type therapy. Of course, P53 reactivators has been interesting, ultimately failed, although I still think there could be some hope in the future. But again, this group is clearly different and may also be different from P53 mutant solid tumor.
But can you explain a little bit more about sort of what happens? It almost sounds like you're saying that, like in AML and MDS, like the P53 is more like a driver mutation compared to the solid tumors. But what about the unfolding of the protein? And I know there was at least one agent, I think it was called APR or something, that was looking at these unfolded proteins.
Yep.
But again, like what are these proteins that you, like for example, that you see there on the IHC?
Yeah, so for P53 to work, its functional conformation is extremely important. So it ultimately, when it's binding to DNA, inducing cell cycle arrest apoptosis, it's often in like a tetrameric state with a very specific conformation that's also able to bind, DNA to an exert. So basically, when you have either contact or structural mutants, this is completely lost. This protein is really in a more naive or unfolded protein, and it can't do any of what it's supposed to. So yes, I think to what you're alluding to, APR246 or epranetatop was a first-in-class P53 reactivator. Actually, really exciting data, went all the way to phase 3 and actually narrowly missed a couple more CRs, and we'd probably be talking about that drug, in addition. Again, there are some work ongoing with that we're a part of, and there are some other specific P53 reactivators for very specific variants like Y220 as an example. So I think that hope of reactivating or refolding a more wild type function of P53, but it's challenging and it may be very specific on the underlying variant.
Great. Thanks a lot. That was very helpful. Please continue.
So what other novel therapies, and I think kind of maybe really the overall scope in my frontline is thinking about novel IO type therapy. And so targeting TIM3 with an agent of sabatolimab has been of considerable interest as well. And TIM3 is kind of unique. So it both has a very clear role on leukemic stem cells where it basically forms this autocrine loop where galactin-9 is made. It actually propagates or stimulates LSC survival. And so if you can block this, you can actually directly target the leukemic stem cell. At the same time, this is a negative immune checkpoint, really similar to PD-1, and its activation or triggering leads to T cells being non-functional. And it may also play a role in antibody-dependent cellular phagocytosis. Actually, a really wonderful trial that has been proposed that I've been a part of that I would love to take leadership in would be sort of an azacitidine, magrolimab, sabatolimab trial. Whether or not that happens or not is beyond the scope of my decision. But again, a novel both leukemia stem cell targeting as well as immune activating therapy. And so I think what I'll focus on, there have been some larger phase 1 data, presented by Andy Bruner at Mass General. But to me, probably the most seminal presentation at this past ASH was presented by Amir Zadan. This was the Stimulus MDS2 trial, which is a randomized double-blind placebo-controlled trial, really speaking to the power of this even being done in phase 2, which utilized hypomethylating agent plus or minus sabatolimab with dual primary endpoints of CR or progression-free survival. And so from a safety perspective, you could actually argue from a combination perspective, sabatolimab has been the safest of all the current really active therapies. From a cytopenia perspective, no difference whatsoever across all the major toxicities if you look at the combination versus single agent HMA, and really just a minor difference in febrile neutropenia. You can see immune-related adverse events speaking to the underlying MOA, but these have been mostly grade 1 or 2, or the rare grade 3 events have been rapidly reversible with corticosteroids. And even in some early data, immune response or immune related adverse events may actually predict response. So again, a really nice side effect profile, something that really everybody in the community would be able to quite easily manage as well. I think, unfortunately, the primary endpoints were negative. Now, from a response perspective, this is not surprising. In phase 1, the CR rate was no different than single agent azacitidine. The real hope is really improving the duration of response, speaking to the IO mechanism of this agent. And again, you could argue how well powered is this? 60, over 60 patients in each cohort. The median progression-free survival was longer, but you could see that the p-value was statistically not significant. But you see this late separation, and it argues, again, longer follow-up, bigger studies, will we see this separation over time? I think what's also interesting is in patients that had lower burden of disease, less than 10% blast, IPSSR that was not very high, maybe speaking against the P53 patient population, then there actually some of these analyses were either positive or really trended to positive. And there is some ongoing work with sabatolimab or sabatolimab combinations in some of the lower risk MDS patient groups, somewhat from these data as well. So again, P53, again, we need to think about this group, by itself. Now, again, relatively small cohort, only about 20 patients in each arm. You could clearly see there was no difference in survival, although in the earlier phase 1, there was sort of an alluding to that potentially being the case. The median survival with single agent HMA here was 15 months, and we struggle a little bit. This is actually better than what we've ever seen with single agent azacitidine. So is there something unique where these lower risk P53 patients, I think, again, small cohort, I don't know what to make of this, but again, it's clearly a cohort that, as we spoke to earlier, needs to really be investigated in detail. This has led to the Stimulus MDS2 phase 3 study, which is, again, a 500-patient trial that includes both very high-risk patients as well as CMML2. And again, this is sabatolimab, actually only once monthly, with, that's plus or minus sabatolimab with azacitidine. And this is nicely only powered for overall survival. Again, I think the negative randomized phase 2 trial has led to some pessimism and a little bit of decreased interest here. But again, the goal is overall survival. And again, if this trial is positive, would be clearly a really great addition to our armamentarium. Again, this may be the last to ultimately read out of the 3 phase 3 trials, but again, I'm looking forward to these data as well. And I think it would be a really nice partner for other combinations like with magrolimab or with venetoclax. So maybe just changing gears in sort of the last couple of minutes is, well, what to do, when you have an MDS patient that has failed standard of care. So, I think in this case, clearly a transplant ineligible patient still has RAB or MDS-IB2 disease after 12 cycles of azacitidine. And so again, there's no standard of care. There's no approvals in that setting. And the patient, really significant pancytopenia, and notable, NGS wasn't done at baseline. And I would say even if it was, it's really important to always repeat it at the time of progression, as clones can change. And notably in this case, the NGS shows an IDH2 mutation. And so although there's no on-label approval, again, there's this overlap. I think the MDS AML actually helps support approvals, and I've actually used that to get off-label drug approvals in that setting. And so enasidenib was utilized in that case. And actually really just fresh off the press again is this publication in Blood Advances by Courtney DiDardo. And they had, it's relatively small, but, again, this is a rare subset. Probably about 8% of all patients with MDS have either IDH1 or IDH2. Again, so you could divide that by the 2. But 27 patients got combo therapy, 23 with monotherapy. And maybe to look at monotherapy, pretty identical to what we see in AML. Not any major difference, and really a profound median survival. If you think about high-risk MDS HMA failure, the average median survival is about 6 months. So here it's 20 months. And then if you look at frontline therapy, the response rate goes up to 74%. Again, if we were applying ELN criteria, probably the true or composite CR response rate would be much higher, but a survival that also looks impressive. And so maybe utilizing IDH inhibitor therapy earlier. But again, really provocative data that supports its use, especially if patients don't have alternative options, and really reasons to think about resequencing. There are very similar data with the IDH inhibitor ivosidenib. I've been a part of this study. Really, Courtney DiNardo has also led this. This was just a presentation we had at ASCO a year ago and has been recently updated at EHA. But again, our response rates are good. If anything, in this data set, they're better than what they are in AML. We have true CR rates by IWG MDS criteria of 46%. And actually, these responses were really durable. Median survival was not reached. And we actually hope these data will support an on-label MDS approval in the not distant future. Similarly, in France, there's been several ongoing trials with both IDH1 and IDH2 studies. This was presented by Dr. Sabert several years ago, but looked at different cohorts, including relapse refractory, where they have very similar data, as well as in more treatment naive cohorts where response rates were up to 91% of patients, and even had some interest. If you didn't respond to single agent, they could add on HMA therapy subsequently, which has been done in some studies. So it's just that this is really the only targeted therapies that we can have for MDS, but the data really speak for themselves. And I hope we'll have on-label approvals, but even off-label, I think there is really an option when a lot of these patients would have no alternative. And so again, what is the practice changing potential? You've heard about the three, pivotal phase 3 trials that have really completed accrual, and we're waiting eagerly on the data readout. The only ongoing accruing phase 3 trial in MDS that we were able to really speak about is a select MDS1 trial, which is with the PMO-RARA agonist tamibarotene. That study is ongoing. Again, can we think about other molecular subset targeted therapy? P53 we've talked about a lot. Splicing mutations, which are about 50% of all MDS. IRAK4 inhibitors, other inhibitors. Can we, again, that's probably the biggest unmet need from a targeted perspective. Thinking about total therapy, getting best outcome, MRD eradication, getting them to transplant, maintenance, and then understanding what's going on when these patients relapse. What is this, an HMA resistance mechanism? Is this something different? And again, how we change and impact our frontline therapy will impact our second line therapy, from that setting. And with that, really thank you for listening to me. And again, some of my key collaborators, both at Moffitt, MD Anderson, which I work quite closely with. And then this is just a picture of a beautiful sky in Tampa.
So just a couple of follow-up questions. First of all, how's your patient doing?
That patient has actually been on drug for about 2 years. And I actually have patients as far out as 5 years on IDH inhibitor. So we published, this is a little bit off topic, but we published a couple of low-risk MDS patients where we used the IDH1 inhibitor ivosidenib as frontline therapy because they had severe neutropenia. And I have a patient 5 years out, normal counts, and became normal immediately. So I do think using these drugs early and earlier is where we're going to go, but they're so rare, it's tough for us to definitively prove this benefit.
And I assume you see differentiation syndrome with these patients?
That's the other nice thing, and I think that a good part for maybe to bring up in discussion is that DS and MDS is very rare. So actually in our IDH1 cohort that we recently updated, we've had 0 grade 3 or higher DS events. I think we only had 2 grade 2 events. So part of it, and I like to speak simplistically, is that there's less blast burden, less to differentiate. And so that may speak to why we see that. Whether or not that's the true answer or not is unclear, but the safety has actually been better in MDS patient populations than AML.
And what about FLT3 in MDS?
It almost doesn't occur. It's really probably 1% or less. And actually many of us think that, and this is being recognized by the ELN, FLT3 is really AML defining. And actually that's one of those ones that I don't necessarily agree that, it should be MDS/AML. If I have a FLT3 12% blast, I'm treating that patient as an AML.